Welcome everybody to another edition of Danny Brown Talks Phoenix. I am your host, Danny Brown. And as always, this podcast is brought to you by my real estate company, Myriad Real Estate Group, where we specialize in helping both buyers and sellers in the greater Phoenix area. Today, I am joined by the Jerry Snow, who is a toxicologist at Banner University Medical Center. Welcome to the show, Jerry.
Yeah, it's great to be here.
So tell us a little bit about yourself and what exactly is a toxicologist.
All right. Well, I grew up in a small town in rural Missouri, which I've come a long way from then. So grew up farming with my dad, did not plan on becoming a physician, but ended up that way. My primary specialty is in emergency medicine. So I did a 3-year residency in emergency medicine. And then after doing that for a number of years, I actually went back and did a specialty fellowship in medical toxicology. So when people say toxicology, they could mean a lot of different things. There are forensic toxicologists that do like lab work and investigation. There are clinical toxicologists and some of our pharmacy colleagues that also do toxicology fellowships. And there are medical toxicologists. And so my subspecialty is really the folks that are taking care of patients at the bedside, also giving recommendations for providers, also taking care of these patients, even throughout the state. So my day in and day out is caring for these patients at the bedside, not only at Banner University Medical Center, Phoenix, but also taking care of the children at Phoenix Children's Hospital as well. And then we do consulting over the phone and help manage these patients all over the state. And this could be anything from, bites and stings from a rattlesnake or a scorpion. It could be occupational or industrial exposures. It could be intentional, ingestions where people are unfortunately trying to harm themselves. So we take care of a wide variety of the patients from, the poison center will get calls about patients that, they'll call and it's something totally benign, like, oh, my kid ate some grass, and you're like, they're going to be fine. And then unfortunately, sometimes people get into some, really, really bad things and they're critically ill. So we see a wide range of patients.
So how did you decide to become a toxicologist if even being a medical professional wasn't even on your radar?
So that story begins with when I started college, I was going to be a basketball coach. Everything was about basketball, toward the end of high school for me. So I wanted to coach basketball, teach science. So I always kind of liked science. And then as that went on, I thought maybe I'll do like athletic training or maybe physical therapy, something kind of like care providing, but also related, bringing it back to athletics. But then as time went on, the truth of the whole matter is my family dentist convinced me that I should go to medical school, mainly because he was like, how's school going? I'm like, oh, it's going really good. And here's the things that I'm thinking about doing. He's like, well, if you're going to do that, why don't you consider, going to medical school? Then you can be like the team doctor. You could be an orthopedist, or you can do internal medicine and, take care of the team. And then you will kind of like reach for the stars. He's like, I just hate to see you go another 10 years. And then like, oh man, I really should have went to medical school and become a physician. So then I just did that. And it fortunately worked out for me. So it was, me kind of, trying to do the best that I could and reach for the stars. And I grabbed hold, and I was one of the fortunate people to get to go and become a physician. I consider myself very fortunate to be able to do what I do.
That's very cool. That's an awesome story. And funny how a dentist, a family dentist, is the one that kind of got you on the path that you're on.
Yeah, nobody else was steering me that way. I mean, people were shocked. It was like, in my little small town, it was almost unbelievable that Jerry Snow's boy, as I'm known back home, because I am a junior, went to medical school. Like, it was unfathomable to people. A lot of people that even like I went to high school with, or teachers that I had through the years too. There were a few people that were like, oh, I can totally see that happen. Other people were like, that's not the kid that I had in class. Type of thing. But I was always interested in how things work. Like, obviously on the farm, there's a lot of chemicals. There's pesticides, herbicides, and other chemicals on the farm. And my dad would always caution me when I was in my adolescence, like, be careful, don't get this on you. And I'm like, well, what would happen if a little bit of that, splashed on me? Like, how could a small amount of chemical absorbing through my skin wreak such havoc? Like, how does that work? So I was always kind of interested in that. And the same thing along with like bites and stings. Like, how can a snake, even like a baby snake that's only like 12 or 16 inches long, cause all these problems with its venom? Like, how does all that work? So that was always kind of something I was interested in. And then later in my career, I still kind of was curious about those things. So I think that also always perked my interest when it came to medical toxicology.
Very nice, very nice. So for those that don't kind of understand what you do, maybe give us a little description of what a day in the life of a toxicologist looks like.
Yeah, so I do a wide variety of activities. You know, we talk a little bit about the patients that we take care of at the bedside. So we're at a busy admitting as well as consulting service at the two hospitals that I previously mentioned. So we see, you know, patients every single day if we're the person on service. So I go and I care for those patients. I'm the one that you know, is making the decisions about what goes on with them day to day. You know, make sure that we're meeting their needs to help them, you know, get back and overcome, you know, whatever their, you know, toxic exposure may have been. And then we do a lot of outreach. I go around the valley speaking to different EMS providers, especially like with Phoenix Fire, reaching out to them, educating them, answering any questions or concerns that they may have. In the last couple of years, I've done a lot with fentanyl and fentanyl exposures to first providers, and, you know, kind of debunking some of those myths, because there was a lot of concern about, for instance, if you get that on your skin, are you just going to drop dead? And that's totally overblown. Like, people aren't getting sick because they have a small, limited, you know, dermal exposure to something like that. So that's a lot of what I've done. And we do a lot of education with University of Arizona Medical School. We have rotating medical students, we have residents, we have fellows. And so a lot of these folks are coming to us and rotating with us on our service to learn more about medical toxicology. And also within our department, we do quite a bit of research as well. So we do education, research, and clinical service. So depending whether I'm the person on service or I'm in the office working on some of these educational opportunities or outreach or research. So it's a pretty busy day most days, just depending on what exactly my focus is on that day. And I'm the director of the clerkship there, so I stay pretty busy helping develop curriculum, maintain that curriculum, to make sure the rotators that are on with us for usually a month at a time are getting what they need out of the month, and kind of learning at least the basics and how to care for these patients and when they should consult with an expert, like we have through the Poison Center and everything.
Very nice. And so to take a step back, you had mentioned that you deal a lot with fentanyl. That's an opioid, right? Correct.
Yeah. It's an opioid. You know, works on the same receptors in the body as morphine or heroin, and a lot of other drugs, oxycodone, hydrocodone, all of which some people may be familiar with, mostly which obviously are prescription drugs. But we use it widely, even on our service, to help with analgesia or, you know, pain, especially like with their rattlesnake bites. We also use it to help pain and with sedation for our patients that are on a ventilator. If they've had a really bad exposure, they may be on the ventilator for a couple of days. And so we'll use that to, you know, as an IV infusion to help keep them comfortable.
Very interesting. So I want to dive more into that and kind of talk about the opioid crisis that the U.S. is facing. Of course, there's COVID-19 going on right now, and we're in the middle of a pandemic, but we've had a larger health crisis in this country for a much longer time, revolving around addiction to opioids. So I imagine in your field that you must see a lot of that in the hospitals. Can you touch on that a little bit?
Yeah, absolutely. I mean, Arizona, just like everywhere else in the United States, has been impacted by the ongoing opioid epidemic. It hasn't been as hard hit as some places like West Virginia, Ohio, Massachusetts. There are definitely some states that have had more deaths per capita than Arizona. But I can tell you from being here in the last 3 years that it's on at least a weekly basis, if sometimes not daily basis, that I will see multiple patients either for acute opioid overdose, where they've been reversed with naloxone or Narcan, which you've probably heard of before, and opioid withdrawal. We see a ton. We get consulted often to help manage these patients because they come in the hospital for a variety of reasons. So people may have have certain infections. They may have pneumonia. They may need to have their gallbladder out. They come in the hospital for any number of reasons. But then while they're in the hospital, if they're not getting the substances that they've been using, alcohol is another big one. Like, the patients come in all the time. They're not upfront about their substance use sometimes, and then they start experiencing withdrawal, and they get very uncomfortable. Some people will get very, very sick and symptomatic. So we help oftentimes manage those patients and treat that. But yeah, the opioid epidemic really has not died down. You're not hearing as much about it. I think there's being a lot of funds directed toward helping with that. I know through our Poison Center, we have the Opioid Assistance and Referral Line which is a number not only for providers, but also for lay people as well to call. And it helps people find, like, if they are interested in trying to have help with their addictions and to maybe get off the opioids. It supplies them with resources out there in their communities to maybe get that, or to maybe institute what we call opioid agonist therapies, such as methadone and buprenorphine, which can help substitute and get people off these illicit substances. Because we know that if you replace a prescribed medication, even if it is an opioid, it supplants that illicit use. It decreases crime, it decreases disease, it decreases overdose deaths. It really has an impact and can really, really save some lives out there.
So I'm curious, you mentioned that it hasn't hit Arizona as hard as some of the other states. Do you think, why is that? Is that have something to do with, the legislation, our hospital systems?
I think it has more to do with the substances used, and where, if you look at some of the data where prescription opioid prescribing, like per capita, like we know West Virginia in particular, there were tons and tons and tons of prescriptions being written specifically like for oxycodone. And so I think that you didn't see, you saw wide prescribing everywhere, but some states there was significantly more prescribing. And I think as the restrictions came on around these medications, and they started kind of drawing back on the prescribing of those medications, patients turned to like heroin and other illicit substances because they could no longer get those prescription medications. So I think you didn't see as probably the degree of prescribing here in Arizona.
Okay.
Is one of the major impacts. We don't get me wrong, we still have a major problem here, and
for sure,
every state, every region's a little bit different. So in other states that I've practiced, say like North Carolina, for instance, methamphetamine's a problem there, but the methamphetamine problem here in Arizona is far more widespread from what I see. We routinely take care of patients that are acutely intoxicated with methamphetamine, and have, they come in with very agitated delirium, combative, in an altered state. And that is not uncommon at all. And we even treat children that, get into the substances of their family members or friends of family members, and come in, acutely intoxicated. And we're talking like toddler age, like kids,
wow,
2 years old.
That's crazy. Is it, and this might be more of like a question for a therapist, but I'm curious, someone goes into the hospital, they've been treated with drugs, they've been put under, like if I go into the hospital to have surgery, I'm going to be put under by some pretty strong drugs. Mm-hmm. When I leave the hospital, I'm not just automatically addicted to those drugs. So how does are these substances that people are taking, is it the substance's fault that they're that highly addictive, or is there a deeper underlying issue that's not being addressed? Can you speak to that at all?
Yeah, so Dan, I think it's important that people differentiate between dependence and addiction. Okay, because these are terms that get thrown around a lot, and people don't really have a good handle on defining. So you'll hear about babies being born addicted. Well, addiction is a compulsive use of a drug despite negative consequences. So babies aren't born addicted, they're born dependent. For instance, let's say that you did go into the hospital, you had a pretty major surgery, like broke a major bone or something, where you had to have have a nail in it, have it fixated, and it was like a big deal after a bad car accident or something. So you're on opioids for a solid week or more. Your body will start to physiologically, any of our bodies will start to have some changes in the receptors that are expressed and everything to adjust to that. And so after a week or so, people wouldn't be addicted, but any of us to a certain degree will eventually develop a certain degree of dependence, where when that drug is stopped, you feel a little crummy. After 3 or 4 days, and they know this from prescribing, that's why they've restricted the amount of opioids you can prescribe from out of the ED or from the primary care's office for an acute problem. You don't write somebody for a month's worth of hydrocodone or oxycodone because they, broke their hand or twisted their ankle or, have a laceration. You give them like 3 days of medication, because they know the longer the prescription, the more likely that patient is to develop a problem with the dependence or addiction. So dependence is when that substance is taken away, you develop symptoms of withdrawal. you have a response when it's taken away. Same thing, alcohol works the same way. People regularly ingest alcohol. I mean, weekly, on weekends, socially, and never have a problem with addiction or dependence. But if we drink daily for weeks on end, you're going to develop dependence. You're going to develop a little bit of withdrawal. However, unless you have compulsive use with negative consequences, and despite those negative consequences, you continue to use, obsess, and crave, that's addiction. That's addiction. Everybody develops dependence to an opioid or alcohol with long enough, especially with heavy use, but not everybody becomes addicted. And that's where it becomes more of a complicated, neurophysiology, psychiatric, like what is it genetically even that predisposes someone to addiction versus maybe somebody that isn't. So like you could take 100 people, everybody gets an opioid prescription, and they know that X amount of people in a given group, a certain percentage, let's say 5 or 10%, they're going to go on to have an opioid addiction. But the other, say 90 people are going to take that medication. They're going to stop it, or they're going to, run out over 3 or 4 days, and they're not going to take an opioid anymore.
So would there be something, so let's say I did break my arm, or somebody listening to this is going in for surgery and they're afraid, of these drugs. Would you give people certain advice in terms of if it gets prescribed, like not taking it because of the fear, or?
Right. So no, I wouldn't. My father recently had surgery just a few weeks ago, and he was prescribed hydrocodone, and he took it, I think, for 2 or 3 days, just enough, to get him through those first couple post-operative days where his arm was like really throbbing. He had tore his bicep tendon, which I think I told you at the gym about.
Yeah.
And he's doing very well with it, but he took opioids for about 2 days. So his risk of developing, and he's like in his mid-70s. So if dad was going to have an addiction problem, probably would have already happened.
Sure.
But it's one of those things where people, if you have a history, a problem with a substance, then you definitely need to practice more precaution. But a person who has never had trouble with any type of medications or substances, who takes it as prescribed for short duration, is at very low risk. I would definitely not tell somebody to suffer through the first several days after a surgery because they're scared to take an opioid, pain medication as prescribed. Now there are other alternatives too. You can try Tylenol or acetaminophen. You can take, non-steroidal anti-inflammatory medications if it's approved by your physician to do so, and that might be enough.
Acetaminophen scares me too because of the liver stuff.
Yeah, if you take it as you're supposed to and stay within the dosing guidelines, you're fine. But you're right. I'll see somebody die from that every single year from it. Some of those are accidental. Some of those unfortunately are accidental, where people have a really bad back pain or tooth pain, and it's still hurting, so they take it every 2 or 3 hours instead of every 4 to 6 hours, and they'll develop very significant liver toxicity from it. But I would feel comfortable. I have taken opioids. I had a bike wreck about 10 years ago, separated my right shoulder, and I was still working, so I wouldn't take anything, obviously, as I was working caring for patients. But when I would get home, I would take like a hydrocodone to kind of get through the evening and be able to sleep through the night, because it was fairly uncomfortable if I moved around very much. I did that for about 2 or 3 days. I think I had a total of 12 tablets. So you shouldn't have an issue. The vast majority of people, I would just caution people, like if you had a large supply for some reason, like you had like open heart surgery, and they did give you like a couple weeks worth of hydrocodone, and you'd already been in the hospital for a week or two taking opioids, you should you should watch your family members or monitor yourself to make sure that, you're only taking it when you really have pain. Because what some people will notice is some people like the way it makes them feel. And so then it becomes less of like, I'm taking this because I feel good versus I'm taking it because my pain's really bad. So there are just certain things that you need to look out for. And then obviously anybody who's concerned that they're developing dependence or any type of addiction to a medication, they should seek help.
So that leads me to my next question. So if somebody finds themselves addicted or dependent, or they think one of their family members is addicted or dependent on these things, what sort of help can they turn to?
Yeah, so there are many centers in and out throughout Arizona and in the Valley, particularly because of, the large population located here in the Valley. And there are, people that specialize in addiction, physicians, addiction psychiatrists. There are a number of physicians, even in my group, that also specialize in addiction. And some people specialize in taking care of people in the hospital with addiction problems. Other people take care of people on an outpatient basis. So there are people that specialize in addiction, and that's everything, Danny. That's tobacco use, that's alcohol use, that's stimulants, that's just any opioids, just anything you can kind of think of. Even eating disorders is another good example, because a lot of these things have overlap. And you see a lot of psychiatrists also, as I mentioned, in addiction medicine, because there's so much overlap between mental illness and substance use, and there's substance use induced, psychiatric problems too. But that's what I would encourage people to do. They could go see their primary care doctor. And if they don't have a primary care doctor, they could set something up to be seen by primary care, or they could walk into one of these care centers, depending on what exactly their concern is. But there's definitely resources out there to get problems helping. And with the one thing that the opioid epidemic has done, as I mentioned, it has really increased the funding and the resources that are available to get patients the help that they need. And Arizona, I think, has been very proactive. I think they've done a really good job of putting some laws in place to get people help. Anybody can walk into a pharmacy and get naloxone. So when we have a patient that comes in for an overdose, even if they're not interested at all in getting help, if they have a friend, family member, loved one, significant other there with them, I encourage that person, if the patient's unwilling to get naloxone, especially after an acute overdose where their life was endangered, I'm like, please, it's a state law. You can walk into any pharmacy and buy naloxone. And if you've got a family member that has an opioid use disorder, or you're concerned about their opioid use, or even if a patient or a family member is on chronic high-dose opioids for chronic pain, like if they're taking what we call morphine equivalents, if you're on really high, significant amounts of those people should have naloxone available. If you've got opioids in the house like that, just as a precaution, even if people aren't misusing the drugs.
Do you, so a couple countries, the whole world's kind of facing this issue, and I know a couple countries have taken different routes than the United States has when it comes to drugs. Personally, I think the war on drugs that was started in I can't remember if it was the 80s or 90s, is a giant waste of money and just a complete clusterfuck and failure. But countries like Portugal and Switzerland have decriminalized all drug use across the board. And anyone that is addicted or needing opioids, such as heroin, they can get it, but from a medical facility, and get it from an actual doctor and have nurses. And they have seen massive decreases in organized crime, dependency and addiction on these substances, and the death rate has dropped significantly. Do you have any opinions on kind of the way that those countries have tackled the problem versus, a country like ours?
Yeah, I think there's several of those things, Danny, that probably aren't coming to prime time anytime soon in the U.S.
Sure.
Just because of the way things. I think there's still a lot of old school thought when it comes to addiction. It's kind of more of as a moral failing, more so than a biochemical medical issue. We know that if we do MRIs on these people's brains and certain types of scans, you see changes. There are changes between a person that uses substances brain and somebody who doesn't. And these are people, a lot of people in addiction, they really try to emphasize to people, like, you don't judge somebody for seeking help for their hypertension, their diabetes, their depression, their anxiety, or even other mental illnesses. But it seems like there's such a stigma when it comes to substance use. And so I think a lot of the what we see from a policy standpoint within the U.S., it's going to be difficult to change. Sure. I think we've moved in the right direction in many things. There are places that have set up like needle exchanges. We know that decreases transmissions of hepatitis and HIV. I think things that reduce harm are equally as important. I think that things like believe that some of the countries that you mentioned also have like supervised injection sites.
Yeah.
So a person can go and they can use these substances supervised at a certain place. I think that's going to be very difficult to take place here in the U.S. I mean, I agree with you in some senses. To me, that it seems a little bit obscene to me that a person who gets caught with a small amount of recreational marijuana could go to prison for 5 or 10 years.
Oh, it's ridiculous.
Yeah. I mean, I think that's a little harsh, and especially just having possession of something. And I realize that's the law, and I understand that that's the law on the books and what their intent was. And the war on drugs was supposed to decrease substance use, but there's still a ton of substance use, and I want to make sure.
Well, it still happens, too. The war on drugs. I mean, we'll go off down a tangent, but in my opinion, the war on drugs was an epic failure in that it created poverty and major crime syndicates in our neighbors to the south, in Mexico and South America, and it didn't decrease the use at all, because I think a lot of addiction stems from mental illness and people trying to fill voids in their lives. And abstinence doesn't work for anything, in my opinion. Human beings are flawed creatures.
Well, I think, sadly, something that I see too is once these people are incarcerated too, they don't get the services that they need either. So you're not going to get your addiction's not going to get solved while you're incarcerated for 6 months, 6 years, 12 years. And even people that are incarcerated for a short amount of time, say if you just get 30 days in jail for your possession and then you're out on bond, if you go out and use again, that dependence that you had over the weeks that you were gone, you've lost that tolerance. You don't have the tolerance that you did. So you go out and you're like, I'm going to do the same amount of drugs that I normally would do. And then you die from an overdose because you've lost that tolerance.
I didn't even consider that.
Yeah. No, we see that kind of thing all the time where somebody, immediately after being released from prison or jail will go out, use a substance and probably dose it like they had prior. And those people will have they'll either die or have a near death, experience from their overdose.
Wow. So one of the last things I want to kind of ask you, what is, if you're allowed to talk about it, what's one of the craziest things, over your career that you have witnessed or seen in the hospital kind of take place?
I mean, there's a lot of stories when it comes to
I'm
that.
Sure.
The easiest one I'll share is one that was, it was worldwide news. It was even, reported in England and so forth, and was here locally in the news and was on television kind of around the nation. And that was a gentleman a couple of years back that was acutely intoxicated with ethanol. And they found a snake out by a lake, and he was demonstrating to everyone how you properly handle a snake. And so this is all, it's all documented with cell phone. There's just picture after picture after picture of him posing with said snake, taking selfies with the snake and with friends and family. And there's like this whole story that, like, photograph wise, you can just flip through and see the whole thing unraveling.
You can see the timeline.
This is like in the middle of the night, right? It's a nice timeline, like, okay. And so they eventually are like, okay, man, let's load up in the truck, and we're gonna go to somebody's house, and I'm gonna cook this snake up, show y'all how you dress the snake up. We're gonna eat it. So it sounded like a good idea at the time. So they've got the live snake, and he just holds it. They get in the truck, they drive to the location, and somewhere along the line, when he wants to get in the door or knock on the door or something, I don't know whether he let go of the snake or lost his grip, but it got him right in like the jaw, along his lower jaw.
Wow.
So it bit him in the face. And this is a rattlesnake here in central Arizona. And so then the gentleman is like, okay, well, we should go to the hospital. So snake's still alive, still holding the snake. They get back in the truck. They drive to the local hospital, walking through the ambulance bay doors. Of course, the ER is freaking out because the dude's got like a live rattlesnake still in his hands. And by this time, his face is swelling up like the Elephant Man. I mean, like he's just getting bigger, bigger, bigger. It's spreading down to his neck. So they're like, well, we've got to place a breathing tube down this guy. He's gonna die. He's gonna lose his airway. And he gets a little combative because he's intoxicated and he's like feels like he's suffocating. But after a few attempts, they finally get that breathing tube down and transfer him to us to care for him. And I think he was on the ventilator for the better part of a week.
Wow.
We had to wait for all the swelling and everything to go down, which was, that was a pretty drastic. Most of our envenenations from rattlesnakes here involve either like the hand or, from the knee down. But
Sure.
every once in a while, when somebody's handling a snake, they'll get it to the face, the neck, the eyelid. You can see any number of bites like that. People have been bitten in the tongue before when placing the snake in their mouth, or mocking the snake, kind of like flickering their tongue at the snake. So they would flicker their tongue, and then the snake was like, "I don't like that, so I'm going to bite you in your tongue." And that's also a place you want to get bit above the collarbone for any reason.
Yeah.
Because the amount of swelling and everything that can be involved, it can be life-threatening, pretty quickly.
Well, that's going to lead us into our part 2 podcast. So Jerry's such an awesome guest that I wanted to focus, the first part of the section. I thought, opioids and kind of substance abuse deserved its own podcast. So if you enjoyed listening to Jerry, we're going to do a second part to this podcast where we discuss the dangerous animals that live in Arizona, and what do you do if you've been bitten by one, as well as common household substances that can poison you or your kids, and kind of what to do. So if you've liked this podcast, tune in to our next one with Jerry. We'll also make sure to link in the show notes any of the services that Jerry talked about where you or your family or friends can get help. Opioid addiction is a serious thing, and we need to get it taken care of for sure. So Jerry, thank you so much for spending some time with us today, and looking forward to our next conversation.
All right. Thanks, Daddy. Great being here.
Perfect. Thank you.